Thank you so much, Anna. First of all, I wanted to thank Felicia. Felicia has been really a great source of inspiration for me, and I think for many of you in this room. She's really she sets the highest standards. She puts a human face on fighting cancer, and she's been a phenomenal global advocate on global health. So when she called me last night and said, I want you to do a presentation on integration, as I was boarding the flight, I was a little bit anxious, but nobody can say no to Felicia because she's just so phenomenal. So let me just say I'm delighted to be here today. I haven't worked in Latin America for about 15 years, and the last thing I worked on was a publication on the health of women in Latin America. And that was published in 2000, and it looked exactly at the issues we're discussing today. How can health reform promote women's health and vice versa? How can health reforms take advantage of the women's health agenda? So for me, it's really exciting to be here and to listen to you, to learn from you, and to see all the progress that has been made in Latin America. So I have been working for the last 15 years on sub-Saharan Africa, on Rwanda, on many countries in East and Southern Africa. And the situation with cancer and women's cancer is absolutely dire. It's really a disaster. We have women that arrive at health facilities at stage 3 and 4. They're not aware that they have breast lumps or they have cervical cancer when it's really too late, when the prognosis and the outcome is not good. We have health systems that are not prepared to deal with their problems. And we have households that make massive efforts to do all that they can to access the limited services that exist with the risk of impoverishment. A woman that's diagnosed with breast cancer in Uganda has less than a 50% chance of survival, versus what we heard today in this country and in Latin America, 90 to 99%. One of my colleagues called cervical cancer the African Holocaust. It just kills both cervical and breast cancer kill so many, hundreds of thousands of women. So my presentation is a bit more global, but it touches many of the topics and the themes that we covered earlier. I think that this graph is really very powerful. We see that irrespective of income level, non-communicable diseases, including cancer, are going to predominate the burden of disease. In many of your countries, it already predominates, even in the poorest countries in Africa. By 2030, you see that they're going to dominate the burden of disease due to changes in urbanization, childbearing, and other demographic changes. Now, most of these countries, I'm generalizing here, but I think it applies to some degree to some of your countries. Most of our countries, particularly in Africa, are not well prepared to deal with this. One of the major themes that we've heard is lack of focus on early detection and prevention and screening. In Africa, the shortages of qualified personnel is absolutely dire. You have one pathologist per 1 million population. The number of oncologists, radiologists, all the specialists that we need you can count them on your hands. Obviously, access to drugs and diagnostics remain huge impediments, and then specialized facilities are rare. And they're usually in urban areas. They have long queues, and very few people can access them. And the ones that access them are usually the ones that have the means to access care. I think you've all seen this slide from Felicia's earlier work. There are huge inequities in financial terms and in terms of access to health services. The global funding for NCDs is really dismal. Here it says it's less than 3%. I was just in a meeting in Rwanda where I heard it was less than 1%. So the resources are really very, very scarce, and most of it come from domestic funding and from households in particular. And their distribution is skewed in favor of communicable diseases. So the question is, when we have a growing burden of disease on one hand, we have limited resource, integration becomes really inevitable. Resources are not growing quickly, so we need to find more creative ways to do more with what we have. So I looked up yesterday online to see, to look for a good definition of integration, and this is one from PATH, which, I thought was rather reasonable. Integration is the organization, management, and delivery of a continuing or preventive and curative health services. And I think all the previous speakers alluded to the same thing. So what are the expected benefits? I kind of went through and thought through what are the expected benefits of integration, and I think Anna touched upon this as well, and many of the other speakers, a client-oriented approach. We don't want women navigating the system and going for breast cancer care in one place, cervical cancer somewhere else, maternal health services, so the one-stop shop approach, expanded hours of operation, good referral system, the holistic care. We don't want to save a woman from dying in childbirth and she dies because of cervical cancer. And then the comprehensiveness, investing early in prevention and detection and saving lives early. And from a health system perspective, there are also many economies of scale and efficiencies through joint training, having specialization, leveraging existing platforms where huge investments have been made already. And ultimately, even though we don't have evidence, we want value for money and better health outcomes. What are some of the potential concerns with integration and things just to bear in mind? These are not unsurmountable obstacles, but things to bear in mind. The first one is the excessive workloads. As we ask community health workers and other primary healthcare workers to take on more responsibilities, we have to recognize their workloads are expanding and compensate them for them. Secondly, if we're going to be integrating across different services within the health sector or with the education sector or agriculture sector, they're going to be higher costs. Right? So we have to bear those in mind as well. And then there's the decentralization. If we look at countries like Brazil, we look at Kenya, which is now being devolved, we look at Nigeria, what we think is important at the national level may not be necessarily important at the decentralized level. So that process has to be managed as well. And then finally, for countries that depend heavily on donor funding, which is probably not many of the ones in this room, obviously funds come sometime in an earmarked way and they cannot be used for multiple purposes, which can also be an impediment. So I wanted to give you a couple of sort of uplifting examples of how we use different platforms. And I think this Rwanda HPV vaccine experience feeds in beautifully with Didi's last slide. Here's a country that mobilized high-level political commitment. It brought the private sector on board to provide free vaccines and assure concessional funding in subsequent years. And it used a comprehensive strategy, something called Healthy Days, and they combined that with deworming, they combined that with messages about maternal and child health. They really did a phenomenal job in attaining over 97% of vaccination rates. I don't know how many of your countries can show these kind of figures. So here's an example of a country that has done this and has done it well. I think it's one of the few countries I'm aware of in Africa. The second example I wanted to discuss was Zambia cervical cancer program. It uses the VIA method. It builds on a very strong HIV platform that was invested in over many years. And just as Didi was mentioning earlier, there's a strong emphasis on using community health workers and traditional marriage counselors to raise awareness, to bring the women into the health facility, and to generate the demand for these services. The other innovative thing, Zambia is a large country. They have very few specialized physicians, so they use telemedicine to send in the results into Lusaka, and then there's quality assurance by people, from the national level. Zambia is one of the few countries that has scaled up the VIA method for cervical cancer screening using the pink ribbon, red ribbon platform. and has attained national coverage. Many of the other countries I work on may have a pilot in one region or another, but Zambia is a great example. I'm going to skip over this example just for the sake of time until more time for discussion, but there's a wonderful example from South Asia, from the state of Tamil Nadu. I'll just say a couple words about it. They started very modestly. They started with 2 pilots. They focused on 1 or 2 diseases. They evaluated the results and then monitored and evaluated the impact of what they did. And here you can see some of the results in terms of hypertension, in terms of cervical cancer screening. And most importantly, they scaled up nationwide, statewide. This is one state in India with some very, very impressive results in terms of hypertension, cervical cancer screening, breast cancer. So it was a progressive approach and one that was very much evidence-based and focused on generating evidence. So let me just finish now with a few key lessons from the presentation. I think we all agree that integrated approaches a priori are a good thing. They emphasize the importance of investing in the continuum of care and as Anna was saying, investments along the life cycle. They're beneficial for patients, for households, and for health systems. The second point I wanted to make, not everything can be integrated. So I think we need to think carefully what should be integrated at what level and for what purpose and at what cost. Just a word of caution. And then finally, I think this was Felicia's point as well, we need to generate evidence. We all think integration is a good thing, but we really need the empirical evidence to demonstrate the impact. So let me just finish by saying I was heavily involved on the HIV/AIDS front for about 15 or 20 years. And I remember back in 2000, I was in meetings in Africa where everybody discussed all the impediments, why ARV programs cannot be rolled out. And I think as a global community, we came together, we galvanized, we mobilized resources, we developed integrated models of care, and we saved millions of lives. And we saved millions of children from becoming orphans because their parents are still surviving. So my hope, at least for the countries that I work on in Africa, and for the poorer countries in Latin America, and for all women in the world, is that we mobilize a similar global effort for women's health and women's cancers. Thank you.